Alright, so pituitary, just quickly. Pituitary gland, commonly referred to as the master gland. This is because of its influence on the secretion of hormones and other endocrine glands. So we don't want to have a problem with our pituitary, right? It is controlled by the hypothalamus, which is located in the brain. The major hormones, the anterior pituitary gland, are the FSH, luteinizing hormone, LH, or prolactin. The important hormones secreted by the posterior lobe of the pituitary gland are the vasopressin. It's also referred to as the antidiuretic hormone and the oxytocin. The master gland is small but mighty, right? It's about a pea size. It does have two lobes, we mentioned, the posterior and anterior. First thing we're going to talk about is diabetes insipidus. Central diabetes insipidus has many causes. It is actually the most common disorder of the posterior lobe of the pituitary and is characterized by a deficiency of the ADH, or the vasopressin. Excessive thirst and large volumes of dilute urine are the clear clinical manifestations of this disorder. It may occur secondary to head trauma, brain trauma, or surgical ablation or irradiation of the pituitary gland. Infections of the central nervous system like meningitis and encephalitis, tuberculosis, or tumors like a lymphoma of the breast or the lung could be a cause. Failure of the renal tubulars to respond to ADH. Certain medications may lead to it too, like lithium is an example. And even though we talk about it in this class, but it's actually pretty uncommon in the United States. There's about 3 cases per 100,000. So it doesn't happen very often. Now when I say that they have enormous output, they really do. Greater than 250 mLs per hour. That's extreme, right? Onset can be abrupt or insidious, and it cannot be controlled by limiting fluid intake. You don't want to, attempts to restrict fluids cause patients to experience craving and to develop hypernatremia and severe dehydration. So how is it diagnosed? Well, a fluid deprivation test is done. They will withhold fluids for 8 to 12 hours, or until the body, 3 to 5% of the body weight is lost. So they're monitoring them very frequently and watching them very carefully. The test is discontinued if they show any types of stress. Management objectives are to replace the ADH, to ensure adequate fluid replacement, and to identify and correct the underlying intracranial pathology. Treatment is focused on finding the cause. If we can't find it in the meantime, we're going to treat with some form of vasopressin. Thiazide diuretics may be prescribed. You may place the patient on a low-salt, low-protein diet. We're going to obviously do isonos. We're monitoring for hypovolemic shock, weights. They're at fall risk. Checking urine, especially specific gravity, and we're watching for hyponatremia. next one we're going to talk about is the syndrome of inappropriate antidiuretic hormone, SAIDH. I guess I have to correct that. Okay. It is defined by hyponatremia and hypoosmolality resulting from inappropriate continued secretion or action of the hormone despite normal or increased plasma volumes, which results in impaired water excretion. What we're going to see the patient have is they're going to have reduced skin turgor, orthostatic hypotension are usually absent. Edema in the hyponatremic patient warrants consideration of another hyponatremic state, such as heart failure or cirrhosis. If they have severe or rapid onset of hyponatremia, remember this can cause confusion, disorientation, delirium, muscle weakness. In extreme cases, seizures and coma. Usually these patients, what we're going to do is restrict fluid intake. As far as nursing management goes, we're going to closely monitor eyes and nose, daily weights, checking those urine and blood chemistries, assessing neurostatus frequently. And here's a picture of where you've got the SIADH versus the diabetes insipidus. So you can see the differences just side by side. SIADH, you've got a decreased sodium, increased fluids, decreased urine output. So you got fluid volume excess, whereas DI, you've got the fluid volume deficit, decreased fluids, increased output. Patient's thirsty, okay? Just so you know the differences. And then again, here's as well. And I think that helps, because sometimes you just get them both confused a little bit. And basically, I mean, the nursing management is eyes and nose, you know, and preventing any major long-term side effects. Okay, so that's endocrine. Long lecture, sorry about that, but